Hello everyone and welcome to our module on cerebellar disorders. The cerebellum is called the little brain. It sits in the posterior fossa behind the brainstem and beneath the occipital lobe. And it plays a number of important roles in terms of muscles. It's responsible for posture and balance, also muscle tone, and then coordinating our movements. In terms of anatomy, the cerebellum can be divided up into the middle portion called the vermis and then the outer portions called the hemisphere. You can also divide it by lobe. There's an anterior lobe, a posterior lobe, and then this little piece in the back called the flocculonodular lobe. The major symptom of cerebellar disease is dyssynergia, which is loss of coordinated muscle movements, and we'll talk about that in a second. But some other symptoms of cerebellar disease are shown on this slide. Nystagmus is a rhythmic beating of the eye. This is an example of it shown on the screen. And you can probably appreciate that this person's eye is sort of bouncing horizontally to the left and the right. In cerebellar disease, classically there will be vertical nystagmus, which is up and downbeat nystagmus. Another possibility is that in cerebellar disease you often see gaze-evoked nystagmus. So usually when you ask the patient to gaze at an object in the room, they fix their gaze and that stops the nystagmus. If gazing evokes the nystagmus and does not suppress it, that's consistent with cerebellar disease. And then lastly, nausea and vomiting and vertigo are also common symptoms of cerebellar disorders. Dyssynergia is loss of coordinated muscle activity, as I just mentioned, and there are a couple of elements of cerebellar disease that fall under the heading of dyssynergia. The first one is dysmetria. Dysmetria is loss of movement coordination. A patient with dysmetria will under or overshoot the intended position of their hand. You can test this clinically by asking the patient to touch your finger with their finger. A patient with dysmetria will not be able to do this because they will under or overshoot the target. Another classic feature of cerebellar disease is an intention tremor. In an intention tremor, the patient can't get their hand to the target because of a tremor which worsens as the hand approaches the target. And then lastly, dysdatochokinesia is when a patient can't make movements that require a rapid change of motion. This is usually tested clinically by asking the patient to put one hand in the palm of the other hand and then flip their hand over and over. A patient with dysdatochokinesia is unable to flip the hand in their palm because they can't rapidly change the direction of a movement. The word ataxia means loss of balance, and this is a classic feature of cerebellar disease. There are essentially two types of ataxia, cerebellar ataxia and sensory ataxia. Cerebellar ataxia is due to cerebellar disease, and patients with this form of ataxia develop a wide-based gait. Their problem is that they feel like they're going to fall all the time because their cerebellum isn't working, so they adopt a wide-based gait to try to maintain an upright stance because they feel like they're about to fall over. In contrast, a sensory ataxia occurs when there's loss of proprioceptive sensation from the body. This can occur if there's damage to nerves or the posterior column of the spinal cord. In these patients, the cerebellum is normal. The problem is they can't tell where their limbs are in space because they've lost proprioception. So these patients develop a different type of gait. They classically have a high stepping or stamping gait. Essentially, they're not sure where their foot is in space, so they pick it up very high and then stamp down on the ground, trying to make sure that it goes where they want it to go. The Romberg test is a clinical test that's used to evaluate ataxia. And the idea behind the Romberg test is that when patients have sensory ataxia and they lose proprioception, they will compensate through their vision. So to do the Romberg test, you have the patient stand with the arms out forward and then you ask them to close their eyes. And if they have a sensory ataxia, they will have a positive test, meaning they will lose their balance or fall. A positive test indicates they have a sensory ataxia. In patients with a cerebellar ataxia, they will lose their balance and fall even with their eyes open. Basically, when you have a cerebellar problem, you cannot overcome that by using your vision. You can only use your vision to overcome balance problems if they're related to proprioception. Some other cerebellar symptoms are shown on this slide. One is hypotonia. This refers to loss of muscle resistance to passive manipulation. So patients with cerebellar disease classically have loose, floppy joints, and that's because of loss of cerebellar function. Another classic sign of cerebellar disease is scanning speech. This refers to irregular speech where the words are broken up and separated by pauses, and the patient speaks the words with varying force. So where a normal patient would say, "How are you doing?" a patient with scanning speech will pause between each of the words, and some words will be spoken quietly, some words will be spoken more loudly. That's scanning speech. Just like you can have lesions on the left and right side of the brain that cause symptoms on the left and right side of the body, the same is true in the cerebellum. In general, each half of the cerebellum controls the ipsilateral side of the body, meaning the same side. This is because of some strange anatomy. There's what's known as a double cross. The cerebellar fibers control the opposite side of the cortex, but then the opposite side of the cortex controls the opposite side, arms and legs, which brings it back to the same side as the cerebellar hemisphere you're talking about. In addition, proprioceptive information coming up the right side of the spinal cord goes to the right cerebellum. So when you put all this together, a left cerebellar lesion gives left-sided symptoms, and a right cerebellar lesion gives right-sided symptoms. The clinical manifestations of cerebellar disease vary depending on which portion of the cerebellum is affected by a lesion. Lateral lesions are lesions that involve the cerebellar hemispheres, as shown in this picture, and they tend to affect the extremities more than the trunk, and we'll talk about this in a second. Midline lesions affect the vermis, that's the central portion here, and they tend to affect the trunk more than the extremities. And then the floccular nodular lobe connects to vestibular nuclei, so damage to this portion of the cerebellum usually causes vestibular symptoms, and these are things like vertigo and nystagmus. So as I said, lateral lesions affect the extremities more than the trunk, and this leads to problems coordinating movements of the extremities. So classic lateral lesion symptoms are things like dysmetria and intention tremor. Also, because the legs can be affected, patients can have falls, and they usually fall toward the side that has the lesion. Central lesions, like I mentioned, affect the trunk and midline. So central lesions of the vermis cause truncal ataxia. These are problems standing independently, or if the patient is sitting upright, they can't maintain that upright position because they will fall over. That's evidence of truncal ataxia, a classic finding in a central lesion. In addition, central lesions can affect the floccular nodular lobe, and as we said, this can cause nystagmus and vertigo. The cerebellum can be affected by strokes. The cerebellum is perfused by the posterior circulation. I talk about this in more detail in the second video on strokes, but the posterior circulation receives blood flow from the basilar and vertebral arteries. Branches of these vessels supply the cerebellum, including the superior cerebellar artery, the anterior inferior cerebellar artery, and the posterior inferior cerebellar artery. And if you look at this slide, all these branches of the cerebellum run across the brainstem like the pons and the medulla, so usually patients with cerebellar strokes have evidence of brainstem strokes as well. The hereditary ataxias are a number of hereditary disorders that all involve some component of motor incoordination related to the cerebellum, and hence the name ataxia. There are three important hereditary ataxias. We'll talk about Friedreich's ataxia and spinocerebellar ataxia in the next few slides. Ataxia telangiectasia is more important as an immunocompromised condition, and we'll talk about that in another video. Friedreich's ataxia is an autosomal recessive disorder caused by a mutation of a gene on chromosome 9 that codes for a protein called frataxin. Frataxin is important for normal mitochondrial function, and the mutation that occurs in Friedreich's ataxia involves an increased number of trinucleotide repeats. So many genes have sequences of 3 nucleotides that repeat, and sometimes those sequences become mutated and the gene gains more repeats. In the case of Friedreich's ataxia, it's a GAA repeat section. And so the more repeats that the gene accrues from mutation, the worse the prognosis, because these repeats lead to low frataxin levels. And frataxin, as I said, is a mitochondrial protein. You find lots of it in the brain, heart, and pancreas, and this is where the problems occur in Friedreich's ataxia, because when frataxin function is abnormal, that leads to mitochondrial dysfunction in these regions of the body. The symptoms of Friedreich's ataxia begin in adolescence with progressive neurologic symptoms that involve the cerebellum and the spinal cord. So these are going to be problems of weakness and balance. Degeneration of the spinocerebellar tract leads to problems like ataxia and dysarthria. You can lose the dorsal columns of the spinal cord, and this can lead to problems with position and vibration sense. And lastly, the corticospinal tract can be damaged, and this leads to weakness in the lower extremities with upper motor neuron features. Patients with Friedreich's ataxia often die from hypertrophic cardiomyopathy. I talk about hypertrophic cardiomyopathy in the cardiology section, but it involves enlargement and thickening of the left ventricular walls. Because the pancreas is involved in Friedreich's ataxia, these patients also develop diabetes. They have insulin resistance and also impaired insulin release, and that's caused by beta cell dysfunction in the pancreas. And then the last feature of Friedreich's ataxia to know about is skeletal anomalies. These patients develop kyphoscoliosis, which is a bend in the spine that's shown here in this child on the screen. They also develop foot abnormalities. The classic one is pes cavus, which is a high arch to the foot that does not flatten with weight bearing. That's what's shown in this picture here. This abnormality develops in other neuromuscular diseases as well. You can see it in Charcot-Marie tooth disease. And then spinocerebellar ataxia refers to a group of hereditary ataxia disorders. All of them involve degeneration of the cerebellum and sometimes the spinal cord. All of the affected patients have cerebellar ataxia, and they have variable muscle symptoms depending on which subtype of spinocerebellar ataxia they have. And unfortunately, for all the forms of spinocerebellar ataxia, there are no effective therapies. And you can read more about the different subtypes if you wish. Alcoholic cerebellar degeneration refers to chronic cerebellar disease caused by alcohol use, and it's caused by direct toxicity of alcohol on the cerebellum. It's not caused by thiamine deficiency. Don't get this wrong in a board question. Patients who consume lots of alcohol have degeneration of Purkinje cells in the cerebellum. It primarily affects the vermis, which is in the midline, so this is going to lead to those truncal ataxia type symptoms of midline cerebellar lesions. So these patients classically develop a wide-base gait, and that's because they have cerebellar ataxia from alcoholic damage to the cerebellum. The gait is the primary problem, but they can sometimes develop other cerebellar features, including things like intention tremor and nystagmus. It's a clinical diagnosis made in a patient who has an alcohol use disorder and develops evidence of cerebellar disease. The treatment is to stop using alcohol if the patient can, restore the patient's nutritional status, but even if you do these things, the gait problem usually does not improve and is permanent in patients who have alcoholic cerebellar degeneration. In the video on demyelinating disorders, I talked about how children who have infections like chickenpox, like this boy on the screen, can develop a demyelination syndrome a few weeks later called encephalomyelitis, and that's from demyelination of nerves in the cortex and subcortex. Well, demyelination can also occur in the cerebellum, and when it does, it's called post-infectious cerebellitis. So just like post-infectious encephalomyelitis, this disorder occurs in children days to weeks after a trigger. The classic historical triggers were varicella infection, which caused chickenpox, and measles infection, but these are both very rare due to vaccination. This has also been reported after Epstein-Barr infection or other viral infections. There are also case reports of post-infectious cerebellitis after some immunizations. The main feature is rapid onset cerebellar ataxia. It's usually a clinical diagnosis after you've excluded other problems of ataxia like toxin ingestion, infection, or other CNS disease. And the prognosis is generally favorable. It's usually a self-limited disorder. I'll finish with this slide and mention other cerebellar disorders, which I won't talk about here, but I do talk about in other videos. In the video on CNS malignancy, I talk about a number of tumors that can involve the cerebellum. These include pilocytic astrocytoma, medulloblastoma, and ependymoma. And in the video on congenital neurology, I talk about Dandy-Walker malformations and Chiari malformations. These are both central nervous system congenital developmental disorders that involve the cerebellum. And that concludes our module on cerebellar disorders.